Dentistry is not what it used to be in the private practice or public sectors. Today, we have dental treatment centers, group practices, large hospital dental departments, dental support organizations, DSO clinics. Whether the clinicians in these clinics are from the same countries, natives, or come from diverse countries, their dental training and background vary greatly, especially in terms of diagnosis and treatment planning. These practices are very busy and therefore are subject to inconsistency, misjudgment, and most important, diagnostic errors. Hello, I am Marwan AbouRass, and this is why I prepared this short presentation suggesting that you use the AbouRass Operational Diagnosis Protocol. Who should use the protocol? Clinically, you. One doctor can use the protocol to diagnose a single tooth, a quadrant, or a whole mouth. However, and that's what I've done in this presentation, the best practice is when all the general practitioners in a large clinic use the protocol. They get trained and use it. When 4, 10, or even 20 clinicians work together using the same diagnostic language and approach, that enhances coordination, collaboration, and clinical safety, and most important, quality. Why use it? It's because based on 40 years testing and experience in Pittsburgh, Los Angeles, Riyadh, Saudi Arabia, and even beyond, I didn't just design this protocol. I lived it. I taught it. And I have refined it 6 times based on the literature, observation, and feedback from the users, my doctors. So, what makes it different? The answer is operationalism. The 4R protocol is not passive. Instead of looking at an X-ray, checking a margin of a crown, and guessing what's underneath, no, you don't do that. The protocol is a system in which you remove restoration to discover tooth cracks and what's underneath them, explore canals to see what type of filling material it is and what kind of seal we have, evaluate crowns. You just don't observe, you verify, clinically verify your hands, instruments. You open and see. So what does the 4R stand for? R1 is for report and report. It begins with the patient pain profile, PPP. 55 questions include 16 details for pain history only. 8 for cases with responses, reversible pulpitis. 8 for non-reversible or irreversible pulpitis. 13 for periapical, periodontal infections, emergencies. 10 responses for non-dental, non-endodontic problems. The protocol helps you understand the person, the patient, not the tooth. That's important. R2 is radiographic findings. Here, what you use the 10 ADI, 10 areas of diagnostic interest. A fantastic protocol. Systematically examine the tooth from the crown to the canal, to the bone, to the adjacent teeth. No guesswork. You document the changes that you see in these radiographs. And then you move to R3. R3 is comprehensive pulp and perio. I use extreme cold, no heat, no electricity. And then I use the classic periodontal test: plaque index, percussion, palpation, pocket depth, mobility, fistula tracking, all of that. It's all within the framework of R3. And then we come to the peak, the core, R4, the tooth restorative condition and structural integrity. And I use the Federation Dentaire International guidelines to judge restorations. The bottom line, whether you are treating a tooth, a quadrant, or entire, this protocol equips for you to give you a clear path, an approach, evidence-based roadmap. It's diagnostic. By itself, it's a diagnostic discipline in action. It has been refined by decades of clinical teaching and patient care. The 4R operational diagnosis protocol is not a checklist. It's not just a philosophy. It's an operational framework. So, if you are ready to move from speculation to certainty, from inconsistency to clarity, start using the 4R operational diagnosis protocol. Thank you for your attention.